Good evening, everybody. Welcome to the today's registrar, what shall we say, lecture by Dr. Nithya, registrar in general surgery. It is part of the faculty lecture. So we slowly we want our registrars to become faculty. So we encourage them to also speak, which is good. And so Nithya is speaking about the approach to peripheral arterial diseases today. We have the privilege of Dr. Shravan, consultant vascular surgeon, to moderate and guide us in this. Dr. Shravan is a consultant vascular surgeon at Sagar Hospital, and I think his good counsel and latest approach to the problem will be very welcome. So it is obviously not a didactic session but an interactive session. So students are welcome to stop and question in between. I think Nithya will give us pauses where questions or clarifications can be done. Over to you, Nithya. All the best.
Thank you, sir. Thank you for this opportunity, sir. I'll keep it as crisp as possible. So, yeah, first I'm going to deal in detail about the chronic peripheral vascular disease and acute in the later date. So, first we'll start with the basic anatomy. So, what we have is the cross-sectional anatomy of the arterial wall. So, the inner layer, I think, can you see my arrow mark, right? Uh,
Yeah.
so the inner layer is the tunica intima, and the tunica intima has these endothelial cells. This is nothing but a single layer of endothelial cells which has this glycocalyx. So what happens? This intima layer is the one that is protecting from all this thrombotic effect, because if there is any damage to the endothelial cells, then there will be platelet aggregation and the thrombi formation. So that is the tunica intima. Next will be the tunica media. And this tunica media is something that is going to differentiate between an artery and a vein. In a vein, this tunica media is somewhat thinner compared to an artery. So basically, this tunica media will have a muscular coating. Now, the last layer is nothing but tunica adventitia, which is nothing but your fibrous tissue. Like how we have a serosa for our bowel, the similar is the tunica adventitia. Now, when we talk about the types of arteries, we have this large artery. Example for a large artery would be an aorta. So basically, these arteries are also called as an elastic artery because they have a lot of elastin in their intimal layer, and they help in propagating the pulses that the heart is basically the systolic contraction of the heart gets propagated. So this large artery does that. And next comes a small or the medium sized artery. So medium sized artery are nothing but your femoral popliteal vessels, and these arteries have a lot of smooth muscle layer in it. So these arteries are important for propagating these pulses. And next comes your arterioles. These arterioles are very important for the systemic vascular resistance. So when we talk about the vasoconstriction and vasodilatation, which is the cause for this hypertension, these arterioles are the one that is responsible for the systemic vascular resistance. And last is the capillary, where exactly we have this oxygen exchange. So basically the capillary is the one that communicates with the cell, and oxygen as well as the nutrient exchange happen between the cell and this capillaries. So this is the basic anatomy that we need in order to proceed. Next, coming to the topic proper. So what exactly is a peripheral vascular disease? So basically what happens is we have an artery and there is this cell that is there. So the cell needs oxygen, and the blood is something that is coming, and the capillaries will give the oxygen to the cell. And if there is increase in the demand of oxygen, but the demand is not met from the blood vessel, that is when we say there is some vascular insufficiency, which will later on progress to cause the ischemia and necrosis. So this reduction in blood flow, which causes hypoxia, which in turn causes ischemia and necrosis. This is the definition of peripheral vascular disease. Now, how can you broadly classify a peripheral vascular disease? Like you have an arterial disease, a venous disease, and a mixed one. In the arterial, you have two types, that is the occlusive one and the functional one. In functional one is something like the vasospastic disorder. Like you have a trigger. This popular disease that is the Raynaud's disease that is triggered in a colder climate. So because of some kind of an external trigger, when you have a vasospasm, that is like a functional disorder. Whereas when you have an occlusive disease, this occlusion can be an acute occlusion or a chronic one. Acute, for example, if there is an embolism, suppose you have an infective endocarditis, or if there is some this vegetation which gets embolized, the embolic shower can cause an ischemia immediately. That is the acute ischemia. Whereas this chronic, because of your atherosclerosis and smoking, there can be chronic vascular insufficiency that can cause a chronic limb ischemia. Venous disorders, again, we have your thrombosis and varicose veins. Thrombosis is nothing but your deep vein thrombosis as well as superficial vein thrombosis. Varicosities is when there is a dilated tortuous veins, and mixed is something like an AV fistula. This is just a broader categorization of the peripheral vascular disease. And today we will be dealing about the arterial disease, in specifically the occlusive one. So, and in occlusive one, we're going to deal about the chronic one. So, talking about the risk factors, elderly, why? Because the elasticity of the arteries slowly decreases as the patient's age increases. So these patients are more prone for vascular insufficiency than males, because this in females, estrogen and progesterone have their inherent vasodilatory effect. So it's more, that is one of the hypothesis, and that's why males are more predominantly exposed to these chronic vascular peripheral vascular disease. Then cigarette smoking, because nicotine is a potent vasoconstrictor, and hypertension because of peripheral. What happens is, because of hypertension, there is arteriolosclerosis. The arteries become hard, the stiffness happens, and that also can cause insufficiency. Then hyperlipidemia. Hyperlipidemia, what happens is, because of excessive lipid deposition, there will be plaque that will be formed on the intimal layer, and that it can cause an occlusion. Then obesity. Obesity itself can add a burden to the heart, and also that will further accelerate the atherosclerosis, and there will be plaque deposition in the intimal layer. Then lack of physical activity. So the calf muscle is one of what we call as the peripheral heart. If that is not exercised well, then the venous return will not be sufficient. And if the venous return to the heart is not sufficient, obviously the circulation from the heart will be less. So that could be one reason. And emotional stress, diabetes, these are the things that can aggravate the above mentioned factors. So what exactly is the clinical manifestation? So in patients who
Just a
have...
minute, ma'am.
Sir?
Just a minute. What about other things? You have not talked about homocysteine and all these things?
Sir, other things are genetic, like homocysteine hyperhomocystinemia, and then we can have a protein C, protein S deficiency, and there are factor V lead mutation. These are the other genetic causes that can also contribute to the peripheral arterial thrombosis, sir.
Yeah, just a minute. I thought you would elaborate a bit more on the plaque formation. Are you going to talk about it later, or is this all?
I'll be talking about it, sir, once I come to that topic proper, sir.
So we don't have, I was hope this one, if at all you're not going to talk, I was going to ask questions from other students as to how the plaque is formed and why why plaque, what is the problem with the plaque and all those things.
Yes,
And
sir.
why you need to give the this anti-lipid agents, what is their benefit and all these things. Anyway, while we have interrupted, I will ask Shravan. Shravan, do you want to comment anything up to now?
No, I think
Hello?
she's given a she's given a fairly basic start. Let's see elaborating now, sir.
Okay. Any
Hello?
questions or clarification so far, students? Say yes or no.
No, sir. No, sir.
I suddenly fear that my voice is not being heard if you keep silent. Okay,
Yes, yes.
carry
Oh,
on.
why male is a risk factor?
ನಮಸ್ಕಾರ ಶ್ರೀಕಾಂತ್.
ನಮಸ್ಕಾರ ಎಲ್ಲ ದ್ರೋಣಾಚಾರ್ಯರುಗಳಿಗೆ.
ಒಬ್ರೇ ಇರೋದು ಇಲ್ಲಿ.
ಮಿದ್ದವರೆಲ್ಲ ಪಾಂಡವರು.
ಇದು ವಾಟ್ ಈಸ್ ದ ಕ್ವಶನ್ ಶ್ರೀಕಾಂತ್?
Who is presenting? Who is the why male is
Nithya.
sex is the risk
Nithya.
factor?
Sir,
Nithya.
risk factors are basically to determine who are more prone for this disease, and we can also prevent them, sir. That is
Why male is the risk factor?
Male factor. Why
male.
male is the risk?
Sir, because of estrogen and progesterone in women, they have a vasodilatory, inherent vasodilatory mechanism, sir. But in males, so that itself is one risk factor, sir.
So postmenopausal females are more at risk for developing atherosclerosis.
Postmenopausal, I'm not sure, sir. I'll find out, sir.
No. If your theory is true, then it has to be. Does anyone agree or disagree? No, I think Shrikant, the answer to that question is, though the production of estrogen and progesterone is reduced, it is not completely off. So they will continue to be there and probably exert a protective influence. Shravan, am I right, or is there anything different?
Yes, sir. So I just would like to add one point to this. Even though the overall incidence is higher in males, post-menopausal ladies, the results, they do very bad compared to a male. When you take a male versus female peripheral arterial disease head-on, the severity of the disease and the outcomes are poorer in females compared to males, sir.
Okay. So almost then what Shrikant said is right. Maybe the postmenopausal, the protective effect of estrogen and progesterone is almost completely lost, maybe. If that is that theory is correct.
Yes, sir.
Okay, Nithya, continue.
Yes, sir. So the major clinical manifestation, these patients will always have pain. So when we talk about pain in peripheral arterial disease, there's something called a claudication. Clauda means I limp. So this claudication.
Not Clauda.
Claud.
It's not Clauda.
Claudicose.
Claudicose. Yes. Okay,
Yeah.
sir.
So.
So this patient will start limping because of this severe pain. And when we talk about claudication, there's something called intermittent claudication, which is very specific for this peripheral arterial disease, wherein the patient will start walking, and within after once he start exercising his muscle, there will be pain that starts, and then the patient will have this pain and he will stop his exercise, that is his walking, and in 5 minutes this particular pain will stop. So that is just a brief thing about intermittent claudication. And one of the most common artery that is involved in peripheral arterial disease is femoral artery. And when this pain becomes severe, and when the obstruction or the occlusion is severe, the patient will have rest pain, which indicates a severe disease where, in spite of patient exercising or not, patient continues to have pain. And along with pain, what other things that patient will have is, patient will have tingling and numbness sensation, and that entire limb will be cold compared to the normal limb. And in advanced stages, because there can be changes of ischemia, you will see small ulcerations, and then it can even progress to a gangrene. And I just wanted to ask residents that whenever we have a peripheral arterial disease, why is that we first see a gangrenous changes in the toes? Can someone answer? I think I'll ask individually. Samir?
Yes, ma'am.
Did you get my question? What would be the reason why we
Because
get
the
gangrene in the toes?
supply is less, so
Sorry?
the blood supply is less over the toes.
See, the thing is the obstruction or the occlusion is in the femoral artery, but the first is manifestation happens in the toes. Why? It's a simple answer.
End arteries. First one. Hello.
Hello? Yeah, Vinod?
End arteries, ma'am.
End arteries, still better is basically it's distal.
Capillaries.
Yeah, that is the distal most part of your limb. So that will first get involved. That is why this gangrene starts in the toes and the distal foot. And I wanted to give a clarity between an arterial and a venous disorder. So what exactly happens is in an artery, because of the inflow, the blood inflow, which is being compromised, we will have the manifestations like cold, clammy extremities. And since the cutaneous blood supply is also compromised, the patient will have a dry skin, hairless, shiny skin. Whereas venous disorder, what happens is the venous outflow is occluded. The arterial inflow is there, but venous outflow is occluded. So what happens is there is warm skin, thickened skin, and pigmented areas happen because of the deposition of hemosiderin. And the typical pain when we talk about an arterial disorder is a stabbing pain which worsens with activity. Whereas in venous pain, you get a cramp, more so in the calf region, and then activity actually relieves this pain. That is the starking difference in an arterial disorder and venous disorder. So what happens is the metabolites that are created in the muscle, once the blood supply comes to the muscle, there will be lactic acid and other metabolites that will be there. These metabolites needs to be washed off or it needs to go back. So in a venous disorder, what happens is this metabolites are still accumulated. So that gives you this kind of cramping pain. And also, these ulcers that we see in the arterial areas, arterial disorders, these are more commonly seen in heel, toes, and dorsum of the foot. Whereas in the venous disorder, we see it in the basically over the medial malleolus. And why is it so? Because in a venous disorder is because the venous hypertension is more in that gaiters area. Next, if there is it's an obvious thing that in a arterial disorder, pulse will be absent. Venous disorder, it will be present. And edema is something which is more seen in a venous disorder. Arterial disorder is less likely unless and until if it's a secondary infection is there. Next, when you talk about claudication as such, it should fulfill 3 criteria. One thing is it should be a cramp-like muscle pain, usually in the calf, and this pain develops only when the muscle is exercised, and the pain disappears when the exercise stops. So, and why exactly this happens is because what happens is there is something called a substance P, which get accumulated because of this muscle activity, and the substance P is the thing that will cause this pain in claudication. Then we have this.
No, I'm sorry to interject. I just want to add that
Yes, sir.
what happens is the muscle goes into anaerobic respiration.
Okay, sir.
Okay, so the substance P is produced due to anaerobic respiration,
Yes, sir.
and that's why the pain comes.
Okay, sir.
Yeah, please carry on.
Yes.
I think, Nithya, you said only calf. There is not just calf. You can get hip claudication as well. You can get claudication in the thigh. It depends on the level of obstruction.
Yes.
Yes, sir.
So
Yes.
if there is obstruction in the superficial femoral, then you get calf muscle claudication. If the occlusion is higher up, then you get thigh and gluteal claudication or
Yes,
hip claudication.
yes, sir.
So basically, what sir is trying to tell is when the site of the claudication is one level below the site of occlusion.
Yeah,
Yes, sir.
exactly.
I hope that is clear. So when you have an aortic or a aortic bifurcation occlusion, you will have bilateral gluteal and bilateral thigh pain. If you have a unilateral iliac, you will have thigh pain. When it comes down to femoral, it becomes calf. And even though technically, if a tibial artery occlusion should cause a foot claudication, it is very, very rarely seen. The foot claudication is very difficult to diagnose, and only theoretically they say that it can be seen in athletes.
Okay, sir. So when we talk about claudication, there is we have this Boyd's grading. So Boyd's grade 1 is when the patient experiences pain after walking some distance. The pain disappears, uh, and patient continues to walk. So this is something like a very initial stages of disease. So this is Boyd's grade 1. Grade 2 is when the pain persists and then the patient still continues to walk. So what happens is here it's almost like a mild to moderate occlusion that happens. And then the third one is pain actually makes the patient to take rest. This is when there is a severe occlusion. So these are the three, whenever you ask history to the patient, you need to find out at the exact history, the way he narrates his entire experience, like how he experiences the pain and what he does gives you the kind of grading, and this grading gives you a mental picture of how severe the disease is. So similar to that, we have another classification is Fontaine classification. Stage 1 is when the patient is asymptomatic, like patient come for some other reason, and then during evaluation, we find out. Stage 2 is intermittent claudication, and stage 2A is well compensated, that he's able to do his, a little bit of activity, whereas stage 2B is poorly compensated, where he has to take some break and then only he can walk. Stage 3 is rest pain. Stage 4 is ulceration or gangrene. Then another classification is also there, that is the Rutherford classification. It's almost like the Fontaine only. So that I think postgraduates, I would give you guys as a homework, like you can write down and put it in the group, Rutherford's classification.
Boyd's classification is 5 stages, no?
Sir, 3 grades, sir.
The grade 4 is minimal walking, pain on minimal walking. 5 is pain on rest, at rest also.
Okay, sir.
Only 4, sir. 4 is at rest, sir.
Pain compels to take rest at normal walking. 4 is even at minimum distance walking, he gets the pain. 5 is pain at rest also.
Okay, sir. I'll check that, sir. Yeah, this is what exactly sir was trying to tell us. So depending on the obstruction, how you get the claudication pain, like this aorta iliac obstruction, we get gluteal claudication. And also in this is a specific syndrome called lyric syndrome, where the patient will also have impotence. And iliac obstruction, you will have unilateral claudication in the thigh and in calf, and femoropopliteal obstruction, you will have claudication in the calf. Here what you need to understand is why in a femoral artery, because usually the obstruction happens in a superficial femoral, which continues down as your popliteal, and that supplies the calf, whereas the deep femoral is the one which actually supplies your thigh muscles. That's why whenever we have a femoral occlusion, you will have the calf claudication. And distal obstruction, you will have claudication in the foot and calf, like how sir said, sometimes they will have foot claudication. Then this is something important, that is rest pain. What is a rest pain? Basically, it's a continuous pain caused by severe ischemia, and it is present throughout. And usually what happens is the patient puts the leg below the level of the heart, or typically what you can say is he brings it closer, like he will patient will be sitting and he will flex his thigh and he literally hugs the leg and calf, he massages. That's because one thing is, when the leg is put below the level of the heart, the gravity itself kind of helps. And when he is massaging, that massaging gives him some amount of relief to that pain. That is something like your pain pathway and the gate control theory. The other thing is this: when the patient leaves his leg below the level of the heart, the gravity helps in temporary relief of the pain. Then moving on to the clinical examination, this is something very important for practicals. Like in inspection, what you see is the nutritional changes and all the trophic changes on the toes, foot, fingertips. You will have skin atrophy. There will be calf muscle atrophy, wasting of muscle because of cutaneous vascular compromise, there will be loss of hair, and patient will have ulcers and shiny skin. So inspection, when you inspect, always look for all those things that I have mentioned. Then you have this Burgess postural test where we ask the patient to lift the leg above the level of blood. But one thing is, in our Indian population, this is something which is very difficult to find out because of the complexion of the skin. Usually it's demonstrated in Western countries. What we see is at one particular angle, there will be appearance of pallor. So that is one test. And for the popliteal artery pulsation, we do something called a cross-legged Fuchsig test, wherein we ask the patient to cross one leg over the other. The popliteal artery pulsation will make this leg oscillate. You can see the to and fro movement of the limb that indicates the popliteal artery pulsation is present. And coming to palpation, one thing is your calf muscle, basically the muscle wasting has to be quantified. And one important thing that I want to emphasize here is how you do this calf muscle measurement is, first what you do is you take the normal limb and you see the girth of the muscle, the circumference of the calf where it is maximum. And then from this distance, you have to measure the distance to the nearest bony prominence. Say, for example, the highest girth of the muscle is somewhere here. So from in the normal limb, from here, you measure it from here to the tibial tuberosity, and in the affected limb at the same distance, then you start measuring the calf muscle circumference. So that's how you quantify the muscle wasting. Then, one second. Then moving on to the other things, you need to describe the gangrenous area. Basically, how exactly the sensations around the area. When you talk about any peripheral arterial occlusion, it should always involve the distal neurovascular status. So you need to look for a capillary refill time. And what is the normal capillary refill time, Ainas?
Three
Ainas, are you there?
seconds. Yes, ma'am. 3 seconds. Less than 3 seconds.
3 seconds, yeah, correct. So you first blanch the ball of you blanch the plantar aspect of the great toe, and you see how fast the blood supply comes back. That is the capillary refill time. And the very important aspect here is your palpation of your peripheral pulses. This is something important. As a postgraduate, you need to tell which you need to know how to palpate for a particular artery and where you have to the landmark surface anatomy, and also against which bone you need to palpate. So I assume everybody knows this, but I would like all of you guys to write down all the arterial pulsation, both upper limb, lower limb, and also your facial superficial temporal, facial artery, external carotid artery. All these things I want you guys to write it down against which bone. It's given in your SDAS. Since I'm running out of time, I would request you guys to write down and put it in the group. Next, so these are the checklist for examination. So one thing is, peripheral arterial disease does not stop in examining only the distal neurovascular status or your limbs, but also you need to look at the heart. So look for the other signs of vascular compromise. Say, for example, congestive cardiac failure, you need to look for a raised JVP, edema, basal crepitation, and also take BP in both the arms. I will come to this particular part in a later slide. And also look for palpable thrills and bruise. Now, when we talk about a chronic limb insufficiency, we talk in terms of broad two category of disease. One is the Burgess disease, and another one is an atherosclerosis.
Doc,
So when we talk,
can I add a couple of things in the examination? Anu?
yes, sir, yes, sir.
Yeah. So can somebody tell me what is sunset foot sign? So that is something when you venous guttering and foot pallor that changes to sudden red or purplish color when you suddenly allow the leg to hang down because of dependent rubor. That is called as a sunset foot sign. These are all like just questions for, even though we don't get to see that clinically commonly, examination they may ask. That is one thing. And the gangrene part you'll be coming, or how to differentiate gangrene, types of gangrene you'll be coming, or examination is done with that.
No, sir. Like
Oh.
gangrene, they had already dealt with in amputation, like the basics of it. So I didn't go to the depth of examining.
No, amputation talk I was there. No, there was no discussion on gangrene in that.
Okay, sir. I
So
will
basically, I want people to know what is dry gangrene, what is wet gangrene. Can somebody just elaborate on that? Just a couple of lines. Any of the students?
Come
By
on, man,
gangrene, there will
quickly.
be clear line of demarcation, sir.
Yeah, tell me. So in dry gangrene, you have a
Clear line of demarcation.
hmm.
It
Okay.
will be
No,
usually
if somebody
dry.
asks you, so if somebody asks you, what is the definition of dry gangrene? What would be your answer? So in simple terms, dry gangrene is blackened, mummified tissues, but with superadded infection or putrefaction becomes wet gangrene. It has a very simple definition. Like you said, the main differentiating point is a demarcation zone. In dry gangrene, there is a good demarcation zone between the healthy tissue and the dead tissue. In wet gangrene, you don't get a clear demarcation zone on where the the infection or the ischemia is stopping and where the good tissue is starting. So which part of the body do you think demarcates faster, skin or the bone? Just take a guess.
Skin, sir.
Sorry?
Skin.
No. Bone has a better blood supply compared to the skin and subcutaneous fat. So that's why when you allow somebody to demarcate, let's say we've improved the blood flow by doing some procedure, patient has a dry gangrene. As the time goes, if you see that area conically demarcates, that's because the central bone survives more than the surrounding soft tissue. So, so bone has a better blood supply compared to the soft tissues. That is one thing. Why does the black color of dry gangrene come? It can be some other color, no? Why is it black?
What
Hello?
gets deposited?
I think the sir gave a good clue. What gets deposited there? What escapes the capillaries once you get a capillary breakdown?
Hemoglobin, sir.
Exactly, hemoglobin. So hemoglobin breaks down into iron sulfide, and that gives the black color of gangrene.
I'm actually
Okay.
surprised that you don't know the definite difference between wet and dry gangrene. Okay, carry on.
So
And
yes, sir.
other thing, I think while you touched upon claudication, I think Shravan would agree that they
Yes,
need
sir.
to know the differentiation between arterial claudication, venous claudication, and neurogenic claudication.
Yes, sir. Absolutely, sir.
So I would like to say a few words on arterial, venous, and neurogenic and an osteogenic claudication as well. So in arterial claudication, it is the exercise that stimulates the pain. So once the patient stops the exercise, the pain comes down. Whereas in a venous claudication, exercise relieves the pain. So or when you elevate the limb because of the stasis, and when you start exercising, the calf muscle pumps and the venous return starts happening. So exercise actually relieves the pain. And in a neurogenic claudication, it is something like a postural, because say for example in a lumbar canal stenosis,
Mhm.
so the nerve root gets compressed between the spinal vertebral column. So what happens is when there is a postural difference, when the patient moves forward or backward, that is when this pain is very severe. And also even on taking rest also patient will have this pain. And in osteogenic claudication, it is because of the joint involvement. So when the patient takes the first step only, the patient will start having this pain. So these are the four things I wanted to tell. Sir, is there anything that I should add, sir, regarding the types of claudication?
So,
Shravan, anything?
so that's fairly okay. Other things which I think which should be put in examination is looking for arterial bruits.
Yes, sir.
Arterial bruit is important, and pulse examination, you have to grade the pulse. It's not just telling that the pulse is present or absent. You have to grade the pulse. So grading the pulse again, some people tell it as no pulse, single plus and double plus, with double plus being normal, single plus as feeble and no pulse. And some people add a triple plus for a aneurysmal kind of pulse. So is that still being followed, sir, in the examinations?
I think I'm not sure whether examiners ask that.
Okay,
As long as you say that the pulse is present or absent, I think they are quite happy.
yes, sir. Yes, sir. So after pulse, our natural thing next was immediately we should look for bruit, especially in the femoral. So because that is the only easiest site to get a bruit. An iliac stenosis can cause a bruit. The other sites, generally we don't get a bruit, sir. So in our complete clinical examination, if we don't tell bruit, it was a big mistake.
And
So
other thing is the student should remember, it's probably not so common in India, but much more common in the Western population is if when you feel the pulse, especially in the femoral or wherever, if the pulse feels bounding, then you have to be worried whether there is aneurysm. So you have to look
aneurysm,
for
yes, sir.
popliteal aneurysm and femoral aneurysm, iliac aneurysm. They're all, popliteal is more common, but iliac and femoral can also be there. So you need to, and then your hand should automatically go onto the abdomen also to feel for any abdominal aortic aneurysm. So
Yes.
there is 20% chance of having a popliteal aneurysm if there is abdominal aortic aneurysm. So whenever you feel a very bounding pulse, you have to think about aneurysms.
Yes, sir.
So, Dr. Nithya, you'll be speaking about on this ABA and all that, or
Yes, sir. Yes, sir. I'll be speaking
okay,
about ABS.
sure, okay.
So, moving on to these two broader classification of disease, that is your Buerger's disease and atherosclerosis. Buerger's disease, first let's deal with it. What exactly is Buerger's disease? It's also known as thromboangiitis obliterans. Thromboangiitis. Angiitis here refers to the inflammation. So this is nothing but a non-atherosclerotic segmental inflammatory disease, which is mostly associated with tobacco use. So in Buerger's disease, there is something called a Shinoya criteria. In Shinoya criteria, there is something like the patient will be a smoker. In order to label a disease, in order to label a particular peripheral vascular insufficiency is due to TAO, the patient has to give a history of smoking, and also the onset of the symptoms should be before the age of 50 years. And also the disease is always an infrapopliteal disease. And also the either the upper limb or lower limb will have thrombophlebitis, because what happens here is that the inflammation that is there, it is in all the three layers. We call it as panarteritis. So because of this inflammation, what happens is there is going to be a thrombus that is going to be formed. So when these thrombus forms in your, because of this inflammation, there can be thrombophlebitis in the upper and lower limb. And the other last component of the Shinoya criteria is that there should always be absence of atherosclerotic risk factors other than smoking. So if the patient fits into these things, then you say it is due to TAO. And and on the other side, I would like to say few things about this is that important point is it is going to involve only your medium-sized arteries, whereas atherosclerosis is going to involve your large arteries. And in case I already told you, it is a segmental inflammatory disease. So what happens is, in your medium-sized artery, this can involve one segment, another segment, another segment. So when we talk about something called a distal runoff, which I will tell you in detail when I talk about the CT angiogram, in these cases, what happens is the distal runoff is not so good. Whereas in atherosclerosis, the distal runoff will be relatively better. So this, why I talk about is, this distal runoff is something that will help us in, planning the interventions later on. And when we talk about atherosclerosis, it is due to because of your hyperlipidemia. And when you talk about the formation of this plaque for atherosclerosis, what happens is, first is because of this hyperlipidemia, there is going to be an endothelial dysfunction. Endothelial dysfunction is going to make the LDL particles cross this endothelial layer, and this will start accumulating in the intima of the blood vessel. So what happens is, this LDL particle, once it starts accumulating, it will start activating the macrophages and the inflammatory mediators. So when these macrophages are activated, they will start phagocyting, and more LDL particles will start accumulating. And this collective LDL particles is known as the foam cells. And what happens is, these foam cells and this LDL particles, they form a plaque which is coated with platelets around it. And because of this, you get that particular occlusion there. Atherosclerotic plaque is initiated here. And in this particular disease, what happens is, there is only the intima that is involved compared to the TAO, where the panarteritis, it is intima that is involved. And here the collaterals that is formed is good. Whereas in TAO, since it is segmental, the collateral formation is less, whereas in atherosclerosis, there is a good collateral formation. So this is in short about Burgess and atherosclerosis. Now we will talk something about
Excuse me,
Sir?
how do you differentiate between vasculitis and Burgess disease?
Sir, it is vasculitis will have other manifestations, systemic manifestations also, sir. In Burgess,
Like,
sir, there will be other cutaneous manifestations like erythema nodosum, and the rheumatological features will be there, sir, depending on the which size artery that is. If there is a small, what happens is, when there is medium-sized arteries that is involved, then the granuloma that is, like they'll have other rheumatological features, sir. Not only it will involve only the arteries, sir. It will involve the systemic uh, level, sir.
Shravan, anything?
Sir, vasculitis is a entirely different chapter. One clinical feature which I can add, which will be extremely different, is that the location is not in the toe tips. So that is one thing. Plus, most of the time they get distal leg or above ankle level circumferential serpiginous ulcers, which are extremely painful. So that is one clinical picture, sir. And like other things which he said, systemic involvement will be there, depending on what type of vasculitis it is.
Okay.
Yeah, one thing would like to ask Dr. Nithya, what are the criteria for Burgess? You said one. What is the other?
Sir, I have read only Shinoya criteria, sir.
There's one more called as Olin criteria.
Okay, sir.
So OLIN, Olin criteria. So
Olin.
maybe somebody can check on that and put it up in the group.
Yes,
What is the
sir.
difference between Shinoy and Olin criteria? Both
Okay.
are important even in the postgraduate stage.
Okay,
Any
sir.
particular reason why it is segmental?
Sir, because of it is panarteritis, so the entire
Why it is segmental, not continuous?
that I'm not sure, sir.
It's not, I don't know, that's why.
I think the Burgess disease is very poorly understood in terms of its pathogenesis. So I think we just know what it causes, but we don't know why it causes what it causes. Shravan, am I right, or is there any reason why?
So the one reason which they tell, sir, is collateral formation is faster, sir. So as one region gets occluded, the other region forms a collateral immediately. So especially in young population where you have a lot of pluripotent cells available, and calf muscle region is the common one commonly involved. So one reason which they tell is the good collateralization which we can get in Burgess disease.
In spite of that, they develop gangrene rapidly, no?
Yes, sir. Yes, sir. That many Burgess patients, sir, the imaging would not show any vessel going down, but still they may heal because of the collateral. So very difficult to ascertain whether by imaging whether they will actually heal or not.
Continue.
Moving on to the next topic, this is very important, like the ankle brachial pressure index. So generally the ankle pressure is more than the brachial pressure. So what happens is here, how do we find out this value? One thing is, first we take the pressure of both the upper limb. We tie like how we normally calculate a BP, systolic BP, we take the same systolic BP of both the upper limb. And then for the brachial pressure, for the ankle pressure, what we do is we take a handheld Doppler and then we tie the cuff somewhere distal to the calf. And then we start, first we hear the Doppler, handheld Doppler, you can hear the sound, the Doppler echoes can be heard. And then you start inflating the cuff pressure. And then there will be at one particular point where the, like how we same calculate a systolic pressure, there will be disappearance of the sounds, and slowly when you start releasing at one particular point, you will hear the Doppler sound. So that will be your ankle pressure. So here what happens is you need to take the highest of both. If suppose the right upper limb and the left upper limb, if the right upper limb has a higher brachial pressure that we take, and in the lower limb, whether the right ankle or the left ankle, whichever has the higher pressure, we take that and we divide them. The ankle pressure is the numerator and the denominator is the brachial pressure. So what happens is when there is a compromise, when the ankle pressure comes down, that's when we start having this claudication. When it's less than, when it's somewhere around 0.5 to 0.8, you'll have claudication. And the 0.3, previously it was called for, it is the cutoff for critical limb ischemia. And less than 0.3, we will have gangrene. But these recently the word CLI is now converted. It's now changed with something called CLTI. Vinod, can you tell me what is CLTI and can you define what is CLTI? Vinod? I think I'll answer this. So CLTI is nothing but your chronic limb-threatening ischemia. So what happens is previously when they were talking about critical limb ischemia, it just gives the threshold value of impaired perfusion. But whereas when we talk about chronic limb-threatening ischemia, it's nothing but a clinical syndrome which is defined as peripheral arterial disease, plus there will be rest pain and also gangrene can be there. And also when there is an ulceration in the lower limb, which is there for non-healing, basically it is not healed for more than 2 weeks. So why we use this is this chronic limb-threatening ischemia is more specific for the condition than just critical limb ischemia. And one fallacy about this ankle brachial pressure index is there when the suppose if the ABPI is more than 1 or say 1.1, what happens is it is not like even the perfusion can still be compromised because there is something like calcification that can happen. When there is a calcification, the stiffness of that vessel itself can give you a falsely high ABPI. So there is something called TBI that has come now. So in diabetic patient, as a part of the disease, and an elderly patient, what happens is there will be sclerosis and calcification in their vessel wall. So in them, if you take an ankle brachial pressure index, what happens is it gives you a normal value, which is actually not. So to exactly filter out that, we do something called toe brachial index. In this toe brachial index, there is a specific sensor that is tied around the toe, and that will give you the pressure in the distal most arteries. So basically, what happens is this will give you a value. So the toe brachial index value should be more than the toe pressure should be more than 30 millimeters of mercury. So if it is less than 30 millimeters of mercury, which means there is a significant compromise. And when we talk in terms about the microcirculation, there is something called TCPO2, which has come up recently. Here, what we do is we measure the partial, it's called TCPO2 is called transcutaneous partial pressure of oxygen. Like we are going to see the transcutaneous pressure of the oxygen. It's nothing but a non-invasive method wherein you see the skin microcirculation, whether it is adequate or not. So what happens is in TCPO2, there is two values. For the upper limb, there is a set of standard value, that is your 58 to 65 millimeters of mercury for upper limb. If the TCPO2 is 58 to 65, it is normal. For lower limb, it is somewhere around 48 to 79. But if it is significantly less, that is less than 30, means there is a compromise, and it's almost like patient is going to go for amputation. It's such a bad state. So these days, what they say is, not just the ABPI, they calculate something like there is a criteria that if the ABPI is less than, not ABPI, the ankle pressure, if it is less than 50, TCPO2 if it is less than 25, and toe pressure if it is less than 30, then around 90% of this patient, or the incidence of amputation among them is significantly higher. So this is something that I wanted to tell you. And next, moving on to the next.
Dr.
Sure.
Dr. Nithya, I just
Yes, sir.
like to add certain things.
Yes, sir.
Okay, so with related to ABI,
Yes, sir.
even in the upper limbs, the
Yes.
brachial artery pressure should be measured with the handle Doppler only. It's not with your stethoscope.
Okay, sir.
Okay,
Yes.
and you're right when you tell you have to take the higher of the right or the left. Why is that?
Because that is the actual pressure, sir. That is the effective circulatory pressure, sir.
No, basically atherosclerosis can affect the upper limbs also.
Mm-hmm.
Correct. So
Yes.
your patient may have a subclavian artery occlusion or an
Mm-hmm.
axillary arterial occlusion. Okay.
Yes, sir.
So that's the reason why you have to take the higher of the two. Second thing, it's not the higher of the right or left side. You are measuring the ABI for the right side separately, you are measuring the ABI of the left side separately.
Okay, sir.
Okay.
Yes.
And you have to measure the ABI of the dorsalis pedis separately and the ABI of the posterior tibial separately.
Okay, sir.
So when you say ABI is 0.7 in right lower limb, that means you've measured DPA and PTA level ABIs, and whichever is the higher is what you mentioned.
Okay. So if the PTA is higher, then I should mention the PTA. And if
Yes.
okay.
In fact, when we do the thing, we write down separately. In DPA, it is 0.52. In PTA, is 0.79, like that.
Okay. Okay, sir.
Is there any way to check peroneal? I know this is slightly proper
Peroneal,
vascular. Is there
lateral
any way to?
malleolus, somewhere
Yes,
lateral.
correct. Right in front of lateral malleolus, you have a anterolateral branch of peroneal. So that is where you will get the Doppler signals of the peroneal artery. So especially in patients having severe tibial disease and peroneal artery flow is good. There are patients who are living only on peroneal artery flow. So for those patients, we have to check in anterior to the lateral malleolus, and you can measure an ABI in that also. Okay,
Yes,
so
sir.
all measurements is through the handle Doppler.
Yes, sir.
Stethoscope has no role at all here.
Yes, sir.
Okay, and you said it can be falsely high, correct?
Yes, sir.
So which common clinical conditions do we see where it is falsely high?
Sir, if there is any calcified plaque and
Yes,
arterial-
where does that calcification come? Which clinical condition which we are seeing day in, day out, where you have extensive calcification? Diabetes mellitus. So a diabetic patient can have extensive calcification in the arterial wall. Second is chronic kidney disease.
yes, sir.
So both these patients, which we very commonly see, can have very high media gets calcified. So medial calcinosis and medial sclerosis will give you a false high ABPI.
Yes, sir.
So why do we go to toe brachial then? So
Because
these
these
falsely high,
yes, sir.
technically we tell as a non-compressible vessel.
Okay, sir.
So for the leg, we tie the calf above the ankle level.
Mhm.
Okay. So in spite of how much ever you increase the pressure above the systolic pressure in the brachial, you still continue to listen to the sounds in the Doppler signals in the dorsal aspiratus and posterior tibial. So these are called as non-compressible vessels.
Oh,
So why is the reason that in spite of a non-compressible ABI, you can still get a TBI?
because these calcifications cannot happen in those digital vessels.
Yes. In digital vessels, you will not have. So what is the normal, I mean, when do you tell TBI is low? You told for ABI. What is the cutoff for TBI?
Sir, TBI is less than 30, sir.
No, you're telling toe pressure. I'm
Huh.
asking toe brachial index.
Toe brachial index. 0.6, sir. 0.6.
0.6, yes.
Less than that.
And yes, like how you have a cuff to measure the ABI and a handle Doppler below the cuff. For the toe, you have a toe cuff, which you put at the base of the toe. Okay,
Yes, sir.
and you have a something called as the PPG probe, photoplethysmography probe,
Yes, sir.
attached to the pulp of the toe.
Mm-hmm.
Okay, so it's similar how you inflate the cuff in the ankle region and deflate the cuff. The toe cuff will inflate and deflate.
Okay, sir.
Okay, so that's how you detect the TBI.
Yes.
Okay,
Yes.
when you can't, when is the condition where you can't do a TBI?
When there is if the amputation of
Exactly.
ray
The toe
amputation.
is not there itself, you can't measure it.
Yes.
Okay.
Yes, sir.
Yeah. Another common thing which you mentioned CLI. So what
Yes.
is chronic limb ischemia and what is critical limb ischemia? Is both the same.
Critical, no, sir. Critical limb ischemia is when the patient is having an imminent, what do you say? The patient is imminent for gangrene. Like it is almost
Hmm.
the verge of compromise.
Hmm.
Chronic limb ischemia is a condition where there is vascular insufficiency for a long duration of time, but we are not very sure whether there is the patient is in imminent gangrene or not, sir.
So basically, in simple terms, chronic limb ischemia is the term for a claudicant.
Huh.
Critical limb ischemia is the term for somebody with rest pain or tissue loss.
Okay.
Very simple.
Yes.
Okay.
Yes.
So, like you said, critical limb ischemia has been replaced by chronic limb threatening ischemia.
Yes.
Okay, that is the new terminology which has come in the latest guidelines.
Yes, sir.
Okay, and the other one which you said is also correct. Or diagnosis for CLTI is rest pain requiring opiate analgesia for at least 2 weeks with confirmed hemodynamic measurements. That is something which so somebody asked, what is the definition of a CLTI?
Okay, sir.
So you should tell it's a patient with ischemic rest pain requiring opiate analgesia for at least 2 weeks with confirmed hemodynamic measurements,
Okay.
criteria number 1, or presence of a diabetic foot ulcer or a non-iliac ulcer for 2 weeks,
Yes.
or established gangrene.
Okay.
Okay.
Yes.
Is there any other investigation apart from ABI, TBI, TCPO2 you told?
Yes, sir. Sir, next is Doppler and
Something before Doppler?
plethysmography.
Yes, correct. Pulse volume recording or air plethysmography.
Yes, sir.
It's more of theoretical for you guys, but it's still mentioned in our general surgical textbooks. So we just still have to know that pulse volume recording, basically it's similar to a BP cuff. You tie it in different levels. One in upper thigh, one in lower thigh, one in upper leg, one in the above ankle.
Okay, sir.
And the cuff is inflated to around 60 to 65 millimeters of mercury. And because it's a tight hugging cuff, any internal changes in volume because of the arterial pulsation, it is picked up by the probe in the cuff.
Okay.
What is the main advantage is that similar to TBI, it is less affected by the calcification.
Okay. Yes.
Okay. If these 2 points, if you know, it is more than enough for the general surgical exams.
Yes, sir.
Yeah. So next is and one another thing, especially if the patient is a diabetic, you should also do a neuropathy check that has to be mentioned.
Yes, sir.
So the way we do a neuropathy check is using the Simmons-Weinstein monofilament test.
Okay.
So that is also a common question. After this only, you should actually move to Doppler.
Okay. Okay, sir.
Yeah, carry on, please.
Yes.
Nithya,
Yes, sir.
how many, this was more slides you have?
More are there, sir, like around 15 more are there, sir.
Yeah, I
So
don't think we can
too
finish
much
it.
information here.
So I think we will have to do this one more class
Yes, sir. I'll do it, sir.
because it's
Your
1 hour now.
Okay,
So
sir.
I think, attention span and all the information that you have given,
Yes,
and
sir.
they should revise it. And maybe what you should do is next class, you ask them questions about what you have told for first 10 minutes and then do the rest of the class.
Sure, sir.
your post DNB,
Sir, post MS, sir.
your registrar here.
Yes, sir.
Yeah,
Yes,
yeah.
Okay.
ಶ್ರೀಕಾಂತ್ ಇದು ಏನಪ್ಪ ಫ್ಯಾಕಲ್ಟಿ ಲೆಕ್ಚರ್ ತರ ರಿಜಿಸ್ಟ್ರಾರ್ ಲೆಕ್ಚರ್ ಅಷ್ಟೇ.
Okay. Too much
Okay.
information with readiness and writing.
I think it was a good class. Students, anybody wants to comment? Students, hello. Somebody say
Extensive
something.
class, sir.
Huh? Come on, bold.
It's an extensive class, sir. Ma'am was focusing mostly about the clinical part and also the differences. In many parts, ma'am clearly tried to portray the differences.
Okay. Shrikant has already said. Shrikant, anything more to add?
No. I had to subtract actually.
Okay. Right. Final comments from Shravan.
Where did you do MS?
Sir, BMC, sir.
Okay.
Shravan, final comments before we end.
Nothing, sir. I think she's fairly touched on the important parts required for general surgical level. We'll take it forward in the next class, sir.
Okay. I think Nithya did a good job.
More
trying
important
to
investigations will come in the next class, sir.
Yeah. So important.
Yes, sir.
She, I think, was able to, sort of correlate clinically and this one, anatomy and all these things. So it's good. I think you guys have to go back and read about this so that the next class, the first 10 minutes will be questions about the last class, and then the next class will
Peripheral
start.
vascular disease in the exams, you won't get diminished pulse. All of them will be absent pulse only.
Yeah, correct.
True, sir. True, sir.
Okay. Okay. All the best and good night. Thank you.
Thank you, sir.
Thank you, Ravi, sir. Shrikant, sir. Thank you, sir.